Hello, I'm Greg Gores from the Mayo Clinic in Rochester, Minnesota. It's a real honor to be presenting at this year's Cholangiocarcinoma Foundation. This has always been my most favorite meeting of the year. Today I will be speaking about perihilar cholangiocarcinoma, abbreviated pCCA, and how we make the diagnosis of this difficult to diagnose disease. Our learning objectives are to define the anatomic cholangiocarcinoma subtype, perihilar cholangiocarcinoma, understand the use of advanced cytologic techniques for the diagnosis of this disease, and obtain insight into the emerging role of plasma cell-free DNA analysis for the diagnosis of perihilar cholangiocarcinoma. To refresh everybody's memory, there are three anatomic subtypes of cholangiocarcinoma: intrahepatic, which occurs in the hepatic parenchyma, abbreviated ICCA; perihilar, which occurs at the union of the right and left bile ducts to form the common hepatic duct, which is above the common bile duct; and then distal cholangiocarcinoma, which occurs in the distal part of the common bile duct. This is a CT scan of a representative patient with intrahepatic cholangiocarcinoma. You'll realize this is an intrahepatic mass. This is a patient with a distal cholangiocarcinoma. One can see the obstruction of the common bile duct with a stricture here and the presence of a stent. And this is perihilar cholangiocarcinoma. This would be the CT scan, MRI, MRCP, and then a ERCP, an endoscopic cholangiogram. No one sees bile duct dilatation, but no mass on either the CT or MRI. The MRCP shows us narrowing here by the malignancy at the junction of the right and left hepatic ducts. And on the ERCP, which is a retrograde cholangiogram coming up, only the right side is visualized and not the left due to this very tight left hepatic duct stricture. This would be a classic picture of a perihilar cholangiocarcinoma. One of the risk factors for this disease is primary sclerosing cholangitis, and the majority of cholangiocarcinomas that occur in this disease are perihilar cholangiocarcinomas. We've looked at over 1,000 patients seen at the Mayo Clinic for the classification of cholangiocarcinoma by anatomic subtype. These are unpublished data given to me by Dr. Lewis Roberts. And you'll note that roughly 49% are intrahepatic, around 43% are perihilar, and 8% for distal cholangiocarcinoma. This would be the representative breakdown where about equal number of cholangiocarcinomas are either intrahepatic or perihilar, and a small subset are distal. It is perihilar cholangiocarcinoma with its obstruction at the of the juncture of the right and left hepatic ducts that causes jaundice and often requires stenting. Because this disease often does not grow into by a mass lesion, but rather as a periductal infiltrating type of cancer, and because it is difficult to access endoscopically, the diagnosis is extremely difficult. Here we see the sensitivity of ultrasound, CT scan, PET scan, and MRI, MRCP. You will notice that MRI and MRCP has a sensitivity of about 88%, so of every 100 patients, 88 would be diagnosed by this technique, whereas only 55% would be diagnosed by PET, 75% by CT, and 55% or so by ultrasound. The specificity of these techniques is about the same as the sensitivity, except for PET scan, which you see as a very low specificity, namely because inflammation in the liver associated with these diseases can result in a false positive PET scan. So what is our toolbox for making the diagnosis of this disease? We have assays on bile duct brushings, so conventional cytology, and then what we use is fluorescent in situ hybridization for FISH. We'll talk about this. Our experience with next generation sequencing of bile has not been fruitful, and we have abandoned such techniques. There are a variety of techniques in the experimental setting, measuring extracellular vesicles in bile, proteomic signatures, and other tests in bile, but they are not practical, have been difficult to scale, and are not used clinically. And then I will talk a little bit about the use of looking at cell-free DNA of differentially methylated regions in the cell-free DNA. So routine cytology is very difficult. There are only a few there's only a few number of clumps of cells on the slide that the cytologist is able to visualize. This would be normal, this would be atypical, this would be suspicious, and this would be positive for adenocarcinoma. So you can see the differentiation between normal, atypical, and suspicious sometimes is in the eye of the beholder. As opposed to conventional cytology, which is subjective, we've used the fluorescent in situ hybridization approach, or FISH. This labels loci on chromosomes. We have 4 colors: a red, a green, this sort of aqua color, and gold. Remember, you have 1 chromosome from each parent, so therefore you should have 2 sets of identical chromosomes, and you should have 2 signals per color in health. In disease, in cancer, the DNA is frequently amplified. One has more than 2 copies of a chromosome. And when we see greater than 2 colors and greater than 2 chromosome pairs, we call this polysomy. And identifying 5 or more cells with polysomy is very worrisome for the presence of cancer in perihilar cholangiocarcinoma. When we've compared conventional cytology to FISH in a large number of patients, the sensitivity of conventional cytology was only 20%. It is still the gold standard and has a near perfect specificity. We were able to triple our sensitivity from 18% to 65% by FISH and still maintain a high specificity. So we routinely use FISH to help make the diagnosis of perihilar cholangiocarcinoma. Recently, we've looked at cell-free DNA, which is looking at DNA in the plasma. And as I said, we've looked at differentially methylated regions as opposed to DNA mutations. And looking at epigenetic changes, such as methylated regions, is able to maintain a high specificity for cancer and sensitivity, whereas looking for mutations has a lower value. So we would look at our overall sensitivity and specificity by receiver operating curves. You can see our overall accuracy is 81%, comparing patients with sporadic perihilar cholangiocarcinoma as compared to those with PSC. You can see that in those without PSC, we actually have an accuracy of almost 90%, but this assay does not perform well in patients with PSC. But this is very promising. How do we wrap all this information up? Well, if a person has an indeterminate stricture and one is worried about cholangiocarcinoma on the MRI and MRCP, we would go next to ERCP with brushings and conventional cytology and FISH. If the cytology and biopsy are positive, one has a diagnosis of cancer. If the patient has a negative biopsy and cytology, but the polysomy is positive and the CA19-9 is high, we would consider this to be probable cancer. If we're uncertain, low CA19-9, no mass lesion, we may repeat the ERCP over time, and then of course it can be positive. If it's persistently positive by polysomy on FISH, we would consider this to be cancer. And if over time the results are negative, then we would go back to routine MRI surveillance. So I thank you for your attention today. I'm happy to entertain any questions anyone may have, and I look forward to the panel discussion. Thank you.